Hi, thank you so much for having me here today. I'm really excited to get a chance to speak with you about dementia communication. My name is Dorothy Colby. I'm with Hale Kuike. I'm the Director of Community Engagement. I'm also a Positive Approach to Care trainer. The Positive Approach to Care is a national and international organization that works to change the culture around dementia care to be a more positive and supportive approach for all people living with dementia throughout their whole journey. So today we're going to focus in on communication. So I wanted to start with one thing, which is taking a look at our personal beliefs. We want to start with understanding that the relationship from the person who's living with dementia and the person who's caring and trying to support them, whether it's their family member, you, the healthcare professional, people in long-term care like myself, neighbors, the relationship is the most critical, not the outcome of any single one encounter. And we are the key to make life worth living. And this is something I think everybody needs to hold close to their hearts and understand. People who are living with dementia are really, truly doing the best they can every single moment, even when the best they can is not very good sometimes. But they really are, with the changes that are happening with their brains as they're moving through this journey, they really are doing the best they can. We have to remember who is the one in this relationship with the healthy brain. It's us, and we are the ones who need to be willing to change, willing to take a step back when things are getting a little tough and we're butting heads, and take a deep breath. They're doing the best they can. What can I try different? What other support can I get in this situation? So starting with this, no matter whether we're talking about communication, challenging behaviors, anything, activities, we want to start with these fundamentals about the belief that the relationship is the most critical. So in terms of communication today, what I want us to focus on is how we take in data from around the world. And when I say we, I mean us, all of us, and people who are living with dementia, because we're all in this boat together. It's all about the brain, and it's all about our brain and the person that we're trying to help's brain, where there's changes going on, physical, structural, chemical changes in the brain, and how that affects how they take in data. So if you go like this with your hands from the world and process it. So we all have these 5 senses that we work with. What you see, so if you look around, we're always taking in visual data. Visual input is king. This is what we as human beings want before anything else. So if you hear a sound out to the side, what's the first thing you're going to do? You're going to look, right? Because you got to see what's coming. So we want to know what's coming before. It's a safety thing. Vision is first. Number 2, so your second finger, what you hear, auditory input. So I mentioned it already. Auditory input is number 2. So you hear something, you're going to check it out. Both of these things start to have changes for those we're caring for, people with dementia. We're going to go into some depth with what changes about how they process visual data and what changes in how they're processing their auditory data. And then the third one, if you take your third finger and touch the back of your hand, sensory input, what you feel and what you touch. We are hardwired, the sensory part of your brain, this up part here. If we like something and it feels good, we keep doing it. If it doesn't feel good in some way, we'll withdraw. It's an automatic reaction. So we want to keep these 3 in mind today especially. There are 2 more, of course, what you smell and what you taste. But we're going to focus on these 3, what you see, what you hear, and what you feel. And the order of those 3 is going to become very important when we're trying to help and support people who are living with dementia. So I want to start by taking a step back and looking at the brain. So one of the things about people who are living with dementia or any kind of brain change, or any kind of dementia rather, caused by whether it's Alzheimer's disease, Parkinson's, vascular or stroke-related dementia. I myself have had multiple family members who have had different kinds of dementia. My grandmother had Alzheimer's disease. My Father had vascular dementia, strokes, and then my father-in-law had Parkinson's. 3 very different people, 3 very different, as you know, disease processes. Each person who's living with dementia is unique in that way, unique in their journey. But these brains that you're looking at here, you can see my cursor on the left, the normal brain, the big fat juicy brain, and then on the right, someone who's passed away with Alzheimer's disease through the end of their life. All dementias, no matter what the cause, are progressive and terminal. So if there aren't other things that cause the end of life, the gradual shutdown in the brain will cause the end of life eventually. And these 2 individuals very generously donated their bodies and brains for us to take a look at that and to see the difference. And the hard thing for us as caregivers with people who are living with dementia, or let me change that to be care partners, we're not just giving the care, we're in this together, care partners, is we can't see these brains from the outside. My head doesn't shrink as my brain is shrinking as a person living with dementia. With other disease processes, it's easier to see and recognize, and therefore easier to empathize. And someone who is living with congestive heart failure or COPD, you see the labored breathing, you see the edema, you see these outward physical manifestations of what's happening to their body because of their organ. The disease is affecting their organs and these organs shutting down. But with the brain, we see behavior changes, and there's a lot we don't see. And going back to how they're taking in information, it's hard for us to get inside and put ourselves not just in their shoes, but in their whole bodies and in their brains, in these in-between brains here. So the one on the left is a healthy brain. The one on the right is end-stage, end-of-life brain. And those who we love and care for and supporting are in between these 2. They might be at the beginning of their journey, or they might be very close to the end. And how can we know what's left in these brains? Because we all know that much, much, much is lost. And the focus is pretty much always on what's lost, okay? They can't find their words anymore. They get lost. They're throwing away their hearing aids. They've become verbally aggressive. There's a lot of these negative changes that are true and do happen, but not a lot of focus is often put on what is left of that changing brain and what they can still do with the right support and care and environment, and what they can still enjoy and be connected with, have that relationship all the way through the end, through that last brain, all the way through the last breath of life. So I want to start with the vision. So we're going to look a little closer on the vision. So I mentioned that it's the most effective sensory input. And if you touch the back of your head, this is your occipital lobe, you can see in the healthy brain on the left, so that's the back of the head with that circle. And then the right-hand side, you can see there's quite a bit of shrinkage and loss there physically. So with all dementias, there's the cells are shrinking and dying, and also the chemical factory that is your brain is kind of putting irregularly along. But those are irreversible physical changes that are happening. So when you talk about the vision center of the brain, we're not talking about the actual eyes. So my eyes are fine. I mean, maybe, of course, I have progressive vision loss, or I have macular degeneration or something, but that's unrelated to dementia. So, but the part of my brain that processes what's coming in through my eyes and then is processed by my brain, that's what's changing. So I'm seeing fine. Taking me to the eye doctor and getting me new glasses is not going to change this part of what's happening in my brain. One of the things that starts to happen, and this is what we're going to focus on kind of a lot today, is I start to become less aware of the edges of my vision. So our peripheral vision, this vision around the edge, and we all know when we go for our driver's license test or renewal, they make you put your eyes in there and they test your peripheral vision, because that's your safety vision. You need to have that little bit of awareness of what's on the sides so you can be alert, right? That starts to go away. Because my brain is shrinking and dying, I can't process as much data, visual data, as I used to before. So my brain very smartly, I'm not stupid, I'm living with dementia, focuses on what's most important, and that is the center active field of vision. So the active field of vision remains, but my brain kind of lets go of this other part because I just can't process it as well. My overall brain is a little slower to process. I see something, it might take me a few more beats than you or younger people. I find that even now, with my a little bit slowing compared to my younger children. But this part is preserved. So safety vision is lost early on. I'm unaware, but my curiosity vision, which is right in the front, is preserved through the end. So how can we understand and put ourselves in the eyes and brain of someone living with dementia and understand what these peripheral changes are and how they affect how I, the person living with dementia, moves through the world, and how it affects how I perceive the world and you. How do I perceive you, or sometimes not perceive you when you think I'm perceiving you? So what I'd like you to try, if you're viewing this from the comfort of wherever you are, at home or office situation or academic situation, I want you to try taking a look. So if you were to stand up, or even if you're seated and you put your hands out to the side and you look straight forward, your eyes are pointed forward, and if you have them out at 180 degrees and you wiggle your fingers, if you are young and in your 20s, you will be able to perceive motion. I am not in my 20s. I do not perceive motion. You might have to move your hands in a tiny bit till you start to perceive it. You might not really see your fingers like I see, but you see something's moving. So for yourself, you can kind of explore what's your range of peripheral vision. Now keep in mind it's 360, not just to the side. The DMV only tests you to the side, but it's 360, so bottom. So as we age, normal aging, not dementia, not diseases causing dementia, we have we have a gradual loss of peripheral awareness. That is normal aging, a little bit. So when we're 20, so if you put your hands back out here again, you're 20, that's great. You have full 180 all the way. When you get to about 75, you can come in about 20 degrees. That's your new, if I turn sideways a little bit, it looks a little like a cone. That's your new field of peripheral awareness. So older drivers get a really bad rap for having scrapes on their cars and parking a little crooked. And if you think about that little bit of change, and that's normal, you need to compensate for it, right? So as I'm getting older, I need to keep in mind, I don't just need to look a little, I need to look a lot as I'm changing lanes because I'm not seeing as much as I used to see. Same for the bottom here. So as you get older, and older I mean 40s, 50s and up, you might find you trip a little more. I didn't see that last step. You're just a little less aware on the bottom side, tripping over roots, tripping over things, just a little less aware. So that's a normal change. So if you look at this slide here, the one on the left with her hands like this kind of simulates this little bit of change I was at. So if you put those on, you can kind of take a look at what you're not seeing on the side. If you take them off, you can see, if you put them on again, you can kind of see a little difference, what you see and what you don't see with those on. So again, that's normal aging. Visual changes, take these visual changes and put living with dementia on top of that. So now, we were 20, we were 75. Now, I'm going to have you put your hands at a 90-degree angle here, like this, so it's a nice V. This cone is now your field of active vision with early dementia. And you can simulate that by putting a snorkeling mask on like this. So you have a snorkel mask on. So, or scuba mask, snorkel mask. And if you take a look, if you're looking straight forward, see what you can see with your peripheral awareness, and then take it off and see the difference and put it back on. What kind of things in the room aren't you seeing when you have that on? Picture someone, or if you have someone in the room with you, please have them do this with you, standing right next to you here, right here. When you have the snorkel mask on, are you aware of them? Can you see them? And if you take it off, now can you see them when you're looking forward? Yeah, you can see them, but when it's on, it's like they're not there. So with this shrinking awareness, now again, I said this first one here, or rather the second one from the left, number 2, that's early. So for myself at Halikwike, we're a memory care home, all of our residents are living with dementia, I tell the staff, picture all of our residents, at least, they don't come to us in the early stage, they come a little further along, but at least like this. At least that they have their goggles on like this. Because if I approach someone from the side here, so I'm coming in and start talking, that was number 2, sensory input, right, auditory, or touching, without the first one, what's going to happen most likely? Jump, right? And so you have that, I don't know how many of you have had this experience. I have had, I can raise my hand many, many times. How many of you have startled someone who's living with dementia and you're not sure why they were startled? It would seem obvious that you were coming towards them or you said, hey, Mom, how are you doing? Before you touched or hugged, but then they jump, or they're startled by someone in a restaurant, like a server or something like that. Take a step back and think about the peripheral awareness change that's happening. It's not that they're not seeing, their eyes are not broken. The brain is changing. They're not seeing everything that you are seeing the same way. So let's move on. So we were 20, we were 75, and then we have early dementia. Now put your hands shoulder width apart and make a circle like this. A circle. So it's really like a tube. You're looking down, and put binoculars on your eyes like this. So now, binocular vision, this is mid-stage, mid to moving towards a little bit later, where I really am starting to have tunnel vision. So my brain is further shrinking and dying, and I just can't take in all this extra data, but everything I want and need is going to be in this range that I'm looking for. So now, if you're sitting at a table, or even if you're standing up, whatever you're doing, kind of try and see what you have to do to take a look at what's on the table, or if you had a spill on your shirt, can you see it, right? If you were looking straight forward and talking to someone across the table at a meal, can you see your own plate, which is down here, without moving your head? No. Whose plate do you see? Your person across the table. I'm living with mid and advancing stage dementia, and I'm hungry. I see food. That's the food I'm going to grab. You hear a lot in long-term care. Oh, careful where you seat them. They steal everybody's food. Do they? They're hungry and they're taking the food that they see. What I see is what I know. And what I see with my brain, where it is at this stage in the journey, is seeing this limited field of vision. Now think about, again, where you're standing as a care provider, medical care provider, or long-term care provider, family care provider. Where would you have to stand in order for me to see you coming? Visual, I want visual data first. Remember, all of us, we want visual data first. To have to come all the way around the front and come in from here. Any amount of side, there's a lot. If you test it with yourself, any amount of side up to about here, I can't see. So it's big changes. And then the last one, we were 20, 75, normal aging, early dementia, mid dementia. All right, how do I do it? Early dementia, mid dementia, and then now later. So if you put those binoculars back on and close one eye, or you can put one hand over here, you monocular vision. So again, I still need to take in some of that essential data, but I just can't process what's going on between two eyes. So with monocular vision, what's lost, and any of you ever wore an eye patch, you would know what's lost when you have one eye that's not available. If you reach down and try and pick up a pen from your table, or if you reach down and try and pick up something on the floor, you'll know immediately your depth perception. Start to have trouble with depth perception. You'll see people living with dementia reaching for things like the light. If you close one eye and look at the lights on the ceiling, can you really tell how far away? If my brain is not working, I might think I could, what is that? Or I might reach for the floor and have a fall sooner than you expect because I can't tell where the floor begins. The distance is really, really hard. So you'll start to notice, and here's the key for helping someone through their journey with dementia, is to be a really good observer, use your visual skills without judgment, and see what you notice. You start to notice they have trouble grabbing the utensil. Maybe they miss a little bit, and then it takes them a little bit to get it. That's a clue that perhaps the depth perception might be changing. So I'm unaware of everything outside my field. So that's something really to keep in mind. You always want to come from the front. So come from the front. If you could picture this, if I have these binoculars on here and someone just leans in and puts their face right in front of me, like, "Hey, how are you doing?" Right into me on the wheelchair. You want to make sure my brain is processing things a little slower. Have a nice enough time to come in and process that you're here. Come from the front. Come in slow. Come from the front. Come in slow. Walk slower than you think you need to. Walk as slow as makes you feel uncomfortable, because I'm used to zipping around, but it makes a huge, huge difference. You can't come in too slow. You can only come in too fast. So that's vision that we want to keep in mind. Auditory input. So auditory input, the part of our brain that processes language, is on the left temporal lobe. Language on the left. You can remember the language on the left, L and L. So you can see here, this is like a slice of the brain, like this way, coming up this way, like a toaster. The left side, the left temporal lobe is affected more severely and very often earlier than the right side. Both sides are affected, but the left side is where your higher language resides. So the ability to generate speech production, speech comprehension, and vocabulary. So my ability to say words and sentences, understand your words and sentences, and to have a big basket of words to pick from, my vocabulary. All those three things have to work together. When there are problems with any one of those three, my language starts to falter. So we might start to notice that someone's not speaking as intelligibly. Of course, if someone is speaking kind of jumbled, that's very obvious. Something's wrong with their language center. But before that, I might start to be a little vague. If you take your hands and go like this, like, I'm looking for the one that was here before, and you're like, what are you talking about? But I'm not able to give you any specifics. Your instinct is to say, what do you mean? What are you talking about? If I could tell you, I would, but this part is not working. So that's where we start to get a little frustrated with these language changes, because I'm being vague or unintelligible and you're trying to understand me, and we just kind of start to butt heads. But the part of this language changes that is not so obvious, that you can't see or hear, is how I, the person living with dementia, is taking in your language. So you're talking to me and I'm nodding my head, and you think that I have just agreed to take a shower because I said, yep. But when we get into the shower, I start to balk. But you said yes. You nodded yes when I asked you if you want to take a shower. Pause, take a time out. Who gets the time out? We do. Take a deep breath. People who are living with dementia, pre-dementia, if you're listening to me speak right now, you are understanding 5 out of 5 words that I say. Unless, of course, you mute the recording or your attention goes elsewhere for a second. But when you come back, if you miss a word, maybe even if you miss 2, you can kind of figure out what's going on. But with the changes that are going on in the left temporal lobe, I start to understand fewer and fewer words out of what you're saying. So maybe I'm only getting 4 out of 5. I can kind of get by. 3 out of 5 gets a little harder. 2, 1, 0. I can hear you fine. I'm not hard of hearing. I'm hard of comprehension. I hear your voice. I hear the music and rhythm of your speech. So I know when you're asking me a question, right? You ready to go? And I'm nodding. What answer do you want me to give you? You're clearly you're giving me a hint. Yep. Even medical professionals do it too. Because that's how we communicate with body language as well. How are you doing? You feeling any pain? No? I'm giving you the answer with my head. Not giving your daughter any trouble, are you? No? Okay, good. Sleeping well? Yep. I'm not stupid. Again, I'm saying I'm not stupid. I'm living with dementia. I'm an intelligent person who's living with dementia. And you don't know what I'm not getting. So what we want to do when we're working with these, helping people with these language changes, is with every words that we're using, combine them with visual cues too, right? So any kind of visual cue you can do. So if you're asking someone like, let's stand up, use a stand up motion too. Are you thirsty? Something to drink? Things like that. Help them put the pieces together, because the visual cues really can connect with the words. Keeping the language simpler, speak slower. I mentioned moving slower, walking slower, but also speak a little slower, low also, because we tend to lose our higher register hearing as we get older. Low and slow will help. The right side of the brain, so the right, we talked a lot about the left, the right side. This part, if you look in the little slide, you can see this part's a little fatter, the right side, than the left side. There's loss, but not quite as much. The right is retained, so language on the left, rhythm on the right. You lose on the left, you retain on the right. Music, poetry, prayer, those are all kind of intertwined. They're rhythmic. Social chit-chat, these things I can do very late into the disease process. I might not be able to speak a full sentence, but I can sing all the words to a childhood song or a song I knew from teenage years. Also, nice and preserved on the right are forbidden words, curse words, sex talk, racial slurs. All those things are preserved, because those are very, very special, powerful words that we all know. Even your sainted mother knows all these words. And we learn not to use it because we have impulse control. And we have a full vocabulary on our left to use other words. So I might think something unkind or think a curse word, but I can use my impulse control and come up with a different way to say it. I really didn't like it when you did that, really. But when I don't have this, and I actually don't have this either, my impulse control is gone, and I have other powerful words, I will use them. And I want everybody to stop and remember, it is not personal. They are people who are living with dementia. Sometimes you'll hear people say, oh yeah, they get really mean when they have dementia. They'll curse at you, and and I've had families ask me, was my mother always really this bad person on the inside, but she was holding it in because now she curses and says, No. This is a disease process that is affecting the brain. And it's my attempt with a dying brain to communicate that I don't like something. So while the words are shocking, you need to try best you can, because it still hurts. If your mother curses at you, it hurts. Believe me, I know. But remember, it is not personal. To take a step back and kind of look at what's behind that. What's happening that's frustrating, and this is how this person is needing to express themselves because they can't any other way. So again, I mentioned hearing's not changed, although a lot of people wear hearing aids. It's the processing, language processing. I'm not hard of hearing, I'm hard of comprehension. But what do we love to do? I'm doing it right now for 30 minutes, blah, 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 blah. We love to talk. We talk our way through and out of so many things, but we want to take a step back. Talking, we have a mismatch. My brain is not processing it properly, and I'm having trouble communicating, and you're trying to use that path anyway, we're just going to miss, and then we're going to conflict. So remember, visual cues first, then auditory cues, and use them together, especially now during this pandemic when we have these masks on, and more. We double masks, N95 masks, face shields. We at Holly Quique, we've been through all these different kinds of maskings at different phases of the pandemic. But even without the mask, it kind of brings the same techniques that we used, positive portrait care techniques before the pandemic. Don't rely 100% on just the verbal. Use your expressions too. You can smile and do things with your eyes, overact it in a sense. But remember, they can't see your lips. It's muffled, and they might not be able to recognize you so well. I'm sure everyone's had an opportunity during this pandemic to not recognize someone. But just remember, and if you need to introduce yourself every time, it's okay. It's okay. Give them a chance. And I appreciate it when people introduce themselves to me, especially with the masks. So remember, visual, verbal, touch. The order matters. Visual, verbal, touch. Don't go for the verbal or touch before the visual cue first. So that's a key to communication. The order matters. So we want to come together. This is how we want to build that relationship before we move on to the next thing. So as care partners. So we might have an agenda, which is, let's say, I need to get you in the shower. I'm writing it on my list. I need to get you to take your medications. Your brief, I think that needs changing too. I'm going to put that on my little list. We're so used to leading with that list and taking that list and putting it forefront and right in the person's face, basically. Time for your shower. Come on, Mom, let's go. Here's your medications. Pause. Get connected first. Visual, verbal. Hey, how are you doing? I'm so glad to see you. Your hair looks great. Oh, wow. Just that human moment to come together and get connected and make them glad that you're there. Before, keep that agenda you had tucked away in your back pocket. It's not going anywhere. Don't worry, you're not going to lose it. And get connected first. That's my biggest message for today. Remember, people living with dementia are doing the best they can, and remember who has a healthy brain, me and you. I want to thank everyone for coming together today to learn about how to make a positive difference in the lives of people living with dementia. On this slide, there's a few resources. The Alzheimer Association, they have, in addition to their 24/7 hotline, they have support groups. Many of them, I believe, are still online, so it really makes it accessible. If you want to learn more about Halikuike, we have a website as well. And we did longer dementia workshops like this one on a variety of topics, 6 or 7 different topics in 2020 with Catholic Charities, and then in 2021 just under the auspices of Halikuike, and we have all those recordings available free online. And if you'd like to learn more about the positive approach to care, that's also at tipasnow.com. So thank you very much, everyone.